Hello, my name is TIPTON McKNIGHT from Pensacola, Florida. I'm with Center for Sight, and my presentation today is use of expand ring in clinical practice. I'll just give you a very short presentation discussing how I came to use the expand ring, how it's inserted, the benefits of the device, and then a few pearls about how you may want to integrate the device into your practice. I want to talk about three things. First, we'll talk about the basic insertion technique, and then I'll talk about where I specifically find the expand ring helpful, and then finally just a few little tips or pearls. So the injection technique is to install the initial foot at the distal iris, and when I first started with the ring, the key thing to learn was not like our intraocular lens injecting from the incision site, but actually inserting the injector almost to the center of the pupil to more carefully and precisely place the foot plate. Then the next step is just placing the lateral feet, and I've found that sometimes it comes out such that both feet will seat simultaneously and effortlessly. If not, usually one will want to go in the right place, and so I'll just tilt my wrist to get the first one in and then tilt the other way to get the second one in. And then the next step is simply, as you can see there, to drop the trailing foot right on the iris surface, and a great instrument, the Williamson manipulator, or very similar to a Coughlin hook, but a little bit smaller and a little bit more polished, to just drop the final foot behind the iris, and then you can see it centers beautifully. That's one of the nicest things about the ring, is that it centers so perfectly. And we obviously want the phaco and the IA tip to go directly through over the proximal foot plate. If it's not that way, the Williamson ring will very easily allow you to rotate a few degrees to get it just right. And then when it comes time to remove the ring, what we do is simply reverse the process. Just take the proximal foot plate, lay it on the surface of the iris, and then remove the lateral and both lateral feet, and then simply grasp the ring on the surface of the iris and bring it back through the wound. So I just thought I would review the different times when I find the ring particularly helpful. First is floppy iris syndrome. It's also really helpful in small pupils in our premium IOL patients, diabetic patients, patients with posterior synechiae, those on anticoagulants or anti-platelet agents, those with iris neovascularization, of course pseudoexfoliation patients, and people who tend to have a tight lid anatomy. So first, with the floppy iris, the 8 points of fixation are especially helpful with the floppy iris patients, because many times I'll encounter a patient where you look pre-op and you think the pupil will dilate adequately, but as you get in there, it's like a little hurricane like we experience on the Gulf Coast, and the iris is really whipping around and can try to come out the incision. So the expand ring with the 8-point fixation really holds it nicely in place. The couple of other tips are that I'll typically make the incision a little further anterior with the IFUS patients, and then also the tunnel not quite so long, because if there's a long tunnel and you're really anterior, then you can get some dimpling of the cornea during the case. Another category that's really helpful is in the small pupil premium IOL patients. These patients obviously expect perfection, and rightfully so. So what I've found is that you really need to preserve the pristine corneal surface in these patients for a couple of reasons. One, so that their healing will be much better. They want to see 20/20 the first day post-op. They want to go home that night and rest and not have any discomfort. And for intraoperative aberrometry, you really need a great corneal surface to get just the perfect intraoperative aberrometry with the Aura or whatever system it is you're using. And we've encountered patients where you're not using the ring, and sometimes it's a little bit small. You don't get quite as accurate aberrometry, or you have a bit of trouble aligning your toric IOL, or if the pupil comes down during your toric IOL case, and you can't get a reading with your aberrometer, then you also can't see any marks you may have placed for alignment. So the expand ring, if we just use it straight out of the gate, then it really just expedites your case and makes it flow smoothly. The other thing is the family, if they're watching on a monitor in another room, it's kind of the biggest wow effect you see. The family loves watching the expand ring go in and out, and it's much more elegant than fighting a small pupil the whole case, and especially compared to the iris hooks. Those do not present well to the family on video. The iris hooks tend to cause a little psychological discomfort. The other thing is with the expand ring, I've found that the pupil will return almost always to a very natural configuration postoperatively, where unless you really, really look carefully, sometimes even on day one you cannot see where the expand ring was in contact with the iris. And it may not seem like much, but if patients have these premium IOLs, they need some reactivity of their pupil for reading vision. It can be really helpful. And if you have somebody with a light blue iris, if there's anisocoria, the patient will not be so happy about it if their pupils are different size. And so this really helps to ensure that you have no peak pupil, no anisocoria post-op. Diabetic patients, we find we have retina specialists who's been very active over the years, and I'll encounter many patients who have had panretinal photocoagulation. The edge of the iris is somewhat fibrotic, and in my experience, some of those you could stretch just with bimanual manipulation and get enough to get through your case. The issue I see with that is sometimes the iris will bleed, and I truly believe, though we've not proven, that you much better preserve the blood-iris barrier so you don't have leakage of red blood cells, white blood cells, and various inflammatory factors into the anterior chamber. And it'd be nice for someone to do a study on this at some point, checking flare post-op at the slit lamp to just quantitate whether that's truly the case. But that's my clinical impression, is you get a lot less flare post-op in these patients, and who knows, it may lessen the incidence of diabetic or cystoid macular edema post-op. Again, can't prove that, but that's my clinical impression. Iritis patients, again, many of these patients have very fibrotic irides from long-standing chronic iritis, and some of them you can get away with simply stretching the pupil, or they'll dilate a little bit, but I've found that the iritis patient, their pupil will often come down during the case, and often at just the wrong time. So if we go ahead and put the expand ring in at the outset, it seems to be much less traumatic, and again, less inflammation on the first post-op day. And I think I'm using less steroids in these patients, and again, don't know, but I think we may get less macular edema in those patients by being as atraumatic as possible to the iris. Pseudoexfoliation patients, I know that there's talk of capsular support with the expand ring, and I've not personally done that yet, but I'm very interested to do so. I do find it very useful in pseudoexfoliation patients because it lets me get the full 6.7 millimeter dilation, and then you can better inspect. I'll even use the Williamson hook and push on, before I make my capsular excess, push on the edge of the lens and just look, and you can really see how much is it wobbling, what are the zonules like, and then kind of get in advance an idea of if you're going to use a capsular tension ring in some of these patients, so that the tech can go ahead and have your capsular tension ring preloaded. And then when you go to put in a CTR with this ring already in place, you can visualize it much more directly and be sure you're getting it in very smoothly and efficiently. Anticoagulants, anti-platelets, iris neovascularization. What I find with that is that with the 8-point fixation, it's not common for me to get bleeding or any significant bleeding. With some of the other devices with single point hooks or with a bit of a pinch to the iris, you can absolutely get some bleeding, and that can certainly interfere with your case and become enmeshed in the viscoelastic. The other place is with tight lid anatomy. Some patients where they've got a lot of really, really tight lids, really deep set eye, or maybe there's a lot of adipose tissue there, it can be very difficult to put the 4-point manual hooks in because you just can't get in there to operate. Or if you get it in and then the patient starts looking around, or they have a Bell's phenomenon and look up, it can really cause quite an issue, and you can even lose capture. And this, of course, is not a problem with the expand ring. Also, I've found that when you do the multiple paracentesis to place hooks, if you have one that's just a little bit off or a little leaky, and you've got that patient who's in ophthalmic, deep set eye, you can get a bit of a lake, and that makes your job a bit harder. So I really like not having to do the additional paracenteses. So I'll move on in closing to just a few tips. One thing I've found helpful is just to mark on the chart before the case, as best I can tell, who's going to be a candidate for the expand ring. That way the tech has everything prepared, and we've gotten away from overutilization of drops. Sometimes in the past the nurses would say, I've put in 6 sets of drops, do you want me to do another one? And then of course that patient's going to be very uncomfortable when they get home, and the corneal epithelium has really been traumatized, and have even seen some cases where you're starting to get a little opacity on the epithelium, which can make your aberrometry difficult. So I find less sloughing of epithelium and better post-op day 1 visual acuity. This other one is obvious, but I'm sure I've done it, and I'm sure everyone will do it once. We tend to use whatever instrument your technician hands you, and if they hand you the IEA, before you've taken the ring out, you will remove the viscoelastic and then have to put it back in to get the ring out. So that's not a huge deal, but we all make that mistake once. If you're reusing the device, it is so light that it's best to hold it on the Williamson ring or whatever you're using to remove the ring, to pass it off into a sterile cup, because the ring is so small and it's so difficult to see on an operating room table, especially for us presbyopes, that you're much better just handing it off on the device like a ring on a pencil. And then the question that often comes up is, how much more time is it going to take you to use this device? And what I've found is it actually saves me time, because in the past, with technologies that you're not that big a fan of, you say, well, I don't really want to deal with using a pupil expander. Let me just work through the case and we'll use it if needed. Then you wind up using a lot more fluid, a lot more corneal edema on post-op day 1, and then it actually takes longer to break everything out, get ready to put in your accessory devices, as opposed to just going straight from the outset and putting the expand ring in. And that's basically it. Thank you very much, and I hope you enjoy using the device.